Hello, everyone, and welcome to another episode in our Smarter in Minutes series. My name is Onyema Ogbuagu, and I am an Associate Professor of Medicine and the Director of Antivirals and Vaccines Research Program in the Yale AIDS Program, Section of Infectious Diseases at the Yale University School of Medicine. Today, I'm joined by my colleague, Dr. Natasha Bhuyan, who's an Assistant Clinical Professor in Family, Community, and Preventive Medicine at the University of Arizona in Phoenix, Arizona. Welcome, Natasha.
Hi, Onyema. Thank you so much for having me.
Our disclosures are shown on the screen. Now, over the next few months, we'll be posting a series of these short CME certified videos focused on the management of patients with COVID-19 in the outpatient setting. This activity is jointly provided by National Jewish Health and Bonum CE. This program has been supported by an educational grant from Pfizer. Now, if you haven't already completed your pre-survey, please do so by clicking the link below this video or by scanning the QR code shown here. Let us know who you are in the polling questions below. Also, please be sure to complete your evaluation at the end of the session and claim your CME credits and watch our handles for additional COVID CME programming. If you're looking for more CME certified programs on Twitter, please follow us at Bonum CE. Now, today, we'll be discussing disparities in the care of patients with COVID-19 in the outpatient setting. Now, let's go through a definition. The Center for Disease Control and Prevention, CDC, defines health disparities as preventable differences in the burden, disease, injury, violence, or inopportunities to achieve optimal health experienced by socially disadvantaged racial, ethnic, and other population groups and communities. And we know that reports have clearly documented disparities in COVID-19 treatment by race and ethnicity, and in other oral antiviral treatments by zip code level and social vulnerability. So Natasha, can you tell us more about how COVID-19 infection risks are increased for historically marginalized, socially vulnerable populations?
Well, disparities exist at multiple levels, including race and ethnicity, worker status, like essential non-health workers, and disability status. Tackling equitable care requires a full range of factors impacting health outcomes like medical access, demographic, and social factors. Public health and federal agencies want to ensure equal access to care, such as the Joint Commission, the CDC, and more. But it's true, like you said, disparities in racial and ethnic COVID-19 health outcomes do exist. There are disproportionately higher rates of COVID-19 infection, hospitalizations, death in relation to share of the US population among American Indian or Alaskan Native non-Hispanic patients, among Asian patients, Black or African American, and Hispanic or Latino. Now, complicating the monitoring and testing of oxygen saturation in COVID-19 patients is the fact that pulse oximetry is not as accurate in Asian, Black, and Hispanic patients compared with non-Hispanic white patients, resulting in delays recognizing guideline-recommended thresholds for treatment initiation. In addition, Black, Hispanic, American Indian, Alaskan Native people experience hospitalization rates 2 times higher and rates of COVID-19 related deaths that are about 2 times higher than those experienced by non-Hispanic white people. Black and Hispanic adults with severe COVID-19 were also more likely to develop certain symptoms associated with long COVID, such as headaches, chest pain, and joint pain. Black adults were also more likely than white and Hispanic adults to be diagnosed with diabetes after having COVID-19. Onyema, can you talk about how access to care and treatments are impacted for our Black, Indigenous, and other people of color, BIPOC, marginalized, and socially vulnerable population patients with COVID-19?
Yeah, great question, Natasha. And I think we'll look at it in two buckets. Multiple factors that increase the likelihood of exposure to COVID-19, and then also would talk about disparate access to COVID-19 treatment. So, for the first issue, we do recognize that some of the drivers of those disparities are that people of color tended to have a greater likelihood of exposure due to the kinds of work that they did and even inability to work at home. And also, even when sick, also had some challenges with being able to physically isolate, particularly those who live in multi-generational households, crowded living conditions, etc. The other factor to mention here is the shift towards telemedicine for providing healthcare. And we know that on an individual level, people not having access to the internet to be able to engage in that healthcare interaction. We also know that individuals had concerns about the loss of wages, loss of insurance coverage, and exacerbated by the end of the free government subsidized testing, vaccines, and treatments that were available. And for certain communities, even concern about immigration status, particularly among individuals in the Hispanic community. The barriers to healthcare access and care, including things like transportation, need for childcare while seeking health services, health literacy, and frankly, that pervasive mistrust by some of these communities, fueled by negative interactions with health authorities and the health providers, all put together put different communities at increased risk of adverse COVID-19 outcome and higher rates of infections. So, to deliver equitable care, it's imperative for clinicians and patient care teams to assess the social factors that are contributing to these access and quality gaps among these patient populations. Now, another thing I wanted to highlight is that there's also the evidence that there was disparate access to COVID-19 treatment. Some studies show that marginalized groups have less access to oral antivirals like nirmatrelvir ritonavir or molnupiravir. And in fact, counties with the highest poverty rates were less likely to have healthcare resources available to vulnerable populations within them, and those individuals were therefore less likely to receive a prescription. So showing you some data compared to whites, and this was consistent across all age groups and immune compromised status, access to antiviral therapy was lower compared to whites by 35.8% among Black people and 29.9% among Hispanic people. And it was also found that oral antivirals were prescribed less in neighborhoods with higher social vulnerability. So, Natasha, given this myriad of issues, what can healthcare professionals do to reduce disparities?
Reducing disparities requires expanded provider education and awareness in a few areas, like raising awareness of important early, timely treatment, like those test to treat programs, and also ensuring there is proactive outreach in the communities and with your patients. We can also prioritize medication distribution to areas of higher social vulnerability. We can also enlist trusted messengers to deliver the messages, like consider community health workers from areas they already serve, since they may already have established trust within those communities. We can also ensure early access to vaccines and updated boosters. For vulnerable individuals like adults and adolescents with moderate to severe immune compromised conditions, consider pre-exposure prophylaxis with new monoclonal antibodies under EUA for COVID, like pemivibart, a monoclonal antibody, which has neutralizing activity against the major SARS-CoV-2 variant, including JN1.
In short, Natasha, it seems clear that there are many things that we can and frankly should do to reduce disparities and decrease the negative impacts of social determinants of health. Now, since we've covered a lot today, Natasha, could you kindly summarize the key points from our discussion, please?
In summary, the key takeaways from today's discussion are: historically marginalized and socially vulnerable populations disproportionately suffer from COVID-19 infections in relation to their proportion of the US population. In addition, access to healthcare resources is hampered by resources available in areas including poverty, insurance status, transportation, childcare, and internet access. Prescription for oral antiviral COVID medication occurred less often for people with health disparities than for non-Hispanic white people.
Thank you so much for joining us today. Please complete the post polls in the tweets below or by using the QR code shown on the screen. And don't forget to claim your free CME. Click like and follow for more social media-based CME from Bonham CE.